In this episode of the HealthBiz Podcast, ChartWise Medical Systems CEO Stephen Mason shares his journey from New Orleans to Nashville, explains how his background in organizational development and consulting prepared him for corporate leadership, and opines on the impact of President Joe Biden's administration on healthcare. We discuss CDI, clinical documentation integrity, and how it's shifting as payment models get more complicated and COVID-19 upends traditional care patterns. I'm your host, David Williams. Thanks for tuning in, and remember, hey Stephen, it's great to have you on the podcast today. How are you?
I'm well. How are you doing?
Doing very well here in late getting into the winter here. So spring will spring at some point, and then we'll see how it's going. So really looking forward to our conversation. And before we get into some of the things that you're doing now, be very interested to hear about kind of your upbringing, your education. What was the sort of the early parts of your life?
Yeah, sure. So nothing too crazy. Was born and raised in New Orleans, Louisiana until fifth grade when my father, who was an attorney at the time, was made general counsel of the company that he worked for, which had a bunch of subsidiaries, and then they wanted him to be general counsel. So we moved to Nashville, Tennessee, and at the time that was a pretty big shock for me. Although I've really enjoyed Nashville, and I married. My wife is from Baton Rouge, Louisiana, so we have a reason to get back to Louisiana quite a lot. So born in New Orleans, pretty much grew up in Nashville, and then went to Ole Miss, the University of Mississippi, and then lived out in Jackson Hole, Wyoming for a couple of years, and decided that while I wanted to, I probably couldn't, make that work professionally for long term. So I went back to graduate school at Vanderbilt University. So it brought me back to Nashville, and I studied. I initially went into the human organizational development program that was sort of focused on counseling from a clinical side, but I ended up switching more to the OD, the organizational development side, and really enjoyed that. I was essentially applying sort of clinical models and analyses to organizations as a way to try to improve both individual and team performance. And so after grad school, I went into consulting.
That's good. I always recommend that to everybody. I did that even before grad school. And I'm glad you started off with the baseline. You said nothing too. Whenever somebody tells me nothing too crazy, and then they start with New Orleans, so if that's your baseline for not too crazy, then it's good. But it sounds like a very sober and kind of professional progression from there.
Yeah, I had my moments, but nothing too crazy. The good thing is I think I got out of New Orleans, before the real fun stuff started.
Yeah.
So that was probably a good move.
That's probably healthy. Now, so consulting, what kind of consulting were you doing?
I worked for a healthcare strategic planning firm, a boutique firm that was founded by a gentleman named Ron Galbraith, who came out of HCA, and Ron's a real thought leader in that space, and so I followed him around for a couple of years, and then eventually was able to lead strategic planning sessions, and the whole focus was around this transformational architecture, sort of a roadmap. So you create the plan, and then you have to sort of figure out all the other pieces and parts that you need to put in place in order to execute the plan. So really learned a ton, from Ron and essentially working with hospitals. We just went around the country and talked to management teams and took them through this process. So it was a great couple of years.
No, that sounds good, and I can see how that's a good kind of precursor, to what you eventually did. So, what did you do after consulting? Did you get, how many things did you do between consulting and getting into ChartWise?
So I did consulting for about 3.5 years, and then like most cases, I ended up getting a job offer from one of our consulting clients. So I'd worked with a behavioral healthcare organization that was a little bit of a roll up, that was trying to figure out their growth plan, and took them through a process. And then they said, hey, how'd you like to come over here and help us, execute this? And it was a great opportunity. And so I jumped over into eventually the chief operating role for a children's behavioral health care, a national children's behavioral health care provider organization, and helped grow that. We grew it almost to 50 states. We got to 45 when we sold the company to another larger children's behavioral health care organization, and then they took the combination of those two companies and they went public. So that was another great experience because I got to get down in the weeds from an operational perspective, and that's really when I first started to appreciate the value that technology has in terms of driving efficiencies and coordination of care. Everything from scheduling to billing to clinical documentation, and we built our own sort of EMR billing system that we actually spun out into a separate company before we sold the operating company. And then I was asked to be CEO of that company. So that was my first foray into the software world.
Yeah, it sounds good. And yeah, certainly children's behavioral health is an area of almost unlimited need and very critical time and challenging for kids and their families. So getting that right from kind of administrative and clinical standpoint is just absolutely essential.
Yeah, yeah, and um, we would provide treatment in the home. So it was called intensive in-home therapy. And we used some technology to ask a series of clinically weighted questions, about how the kids were doing every day. And we'd sort of plot them out on a run chart. And you could tell when their behaviors were escalating, and you could adjust treatment accordingly to try to keep them out of, higher levels of care, which is really what we were trying to do. And that certainly applies today in terms of the behavioral health care role in broader population health management, and the need to be able to successfully treat and control some of those issues that would pop up and put people not only in a higher level of care, but also a more expensive level of care. So it's been pretty interesting to watch the behavioral health care and it come sort of finally fully integrate with the healthcare delivery system through population health management. So it's been pretty. I'm still interested in that. I left when we sold it, and then we sold the software company, and I got back into acute sort of inpatient healthcare. But I kind of imagine maybe going back over into the behavioral healthcare side at some point in the future.
Good. No, it's a great area, and I'm sure there'll still be plenty of need by the time you get back into it. So
Yes.
let's talk about clinical documentation. So first of all, what is it? What do we mean by clinical documentation?
Yeah, so it started out as clinical documentation improvement. So the acronym is CDI, um, and essentially what it is a pretty simple concept applied to a very complex um, sort of situation, which is in general healthcare and the documentation of it, and then the documentation obviously has to translate to sort of billing codes and so what clinical documentation improvement and now it's really more the I has been substituted now for integrity. So clinical documentation integrity, which basically means that everything that you're documenting is accurate, it's precise, it's complete, and it reflects the true state of acuity of every patient. So we're trying to capture not only the primary diagnosis, which is what you would get without clinical documentation improvement, and also capture all these other things that are going on with the patient as a way to get a full picture, but also as a way to get full, complete, entitled reimbursement. And so there's a financial element to it that is valuable, but most CDI programs are about getting it right from a
Hmm.
clinical perspective, and then what flows out of that should be complete billing, not necessarily improved billing, but getting the expression out there, not a penny more, not a penny less, right? And without it, it's really hard to do because it's impossible for a physician to memorize all the ICD-9 codes and ICD-10 codes and all the other things that they have to document in the right language in order for it to count. right? So there's 20 different types of sepsis. And so if you just say sepsis, you're only going to get X. But if you say sepsis with X, Y, and Z for a patient who is this age and has this and this in terms of secondary comorbidities, then the reimbursement profile changes. It becomes a higher weighted case. And then what ultimately gets produced is the DRG, the DRG weights that drive the billing. So it's a way to automate all of that complexity, to help physicians document not accurately, but the way they need to do it in order for the billing to sort of play out.
Got it. So, so I guess we probably don't want physicians spending all of their time knowing all the permutations of ICD-9, never mind ICD-10 codes. It could be concerned about a physician that was able to memorize all of those codes. That would be a little bit weird to do it. But how much of what you're describing, so the way you described is sort of, you want to document everything properly from a clinical standpoint, and then that will naturally drive the billing. I don't know, if you've done any international comparison or anything, but certainly with a fee-for-service billing system in the U.S., that the driving of that reimbursement is critical. How much of the way CDI is done here is related to the fact that we've got this particular type of billing system?
95% of it. Just the vast complexity of it drives that. And what CDI does is it takes all these. So physicians like to abbreviate. They like to just sort of get to the point. And there are also other things that are going on with the patient that the physician may not be aware of at the time that they're documenting it. And so it's really hard to sort of, for one person to have all the knowledge, to have the time, and to have all the information. And so what we do from a CDI perspective is we use technology to go out and analyze the EMR, the patient record, using natural language processing. And it funnels all that stuff down into a rules engine that starts to look at the information and draw some conclusions. We call it like a market basket analysis, right? If you go and you get, milk and eggs, what are the chances you're also going to buy bread and butter or bacon? And so we can do that in a way that basically says to the physician, hey, this person has congestive heart failure. That's great. You documented that. But did you also know that they're hypertensive, they're type 1 diabetes, they have acute, kidney issues, and basically go find it and present it to the physician, and then ask them to document based on that and to confirm some of those things. And when they do that, then you say, okay, the doc has now documented these things. We found them in labs and other stuff. But if the doctor puts it into essentially a note, then that can trigger a different code that would be more relevant. And that would also drive the reimbursement according to all of those things, as opposed to just the primary thing, which the physician documented. So it's all the little, sort of nuanced pieces of information that are going on with the patient that we capture and bring to their attention.
Got it. And then it's the difference between the doctor doing a good job with the patient and going out of business versus being able to run the practice effectively and making reasonable living.
Yeah, absolutely. And all we're trying to do is help them get paid for what they've done, right? So they might be treating the diabetes. If somebody has congestive heart failure, if they have type 1 diabetes, they're also dealing with that. However, the physicians may not document that because in their minds, it's congestive heart failure, on chronic with complications. And so we're just trying to make it really easy for all of that to be documented the correct way. And then we do the crosswalk to the codes, because the physicians and other folks literally they don't need to spend time doing that.
No.
And so we just try to help them get it right. And then we do the translation, and then that's what goes into the billing system to be billed.
Now, this is, as you mentioned, a very complex and nuanced space. It's also one that's not static, and there've been a number of things that have happened over the past few years that I've followed, sort of at the level of the acronyms. So I think about, the shift from ICD-9 to ICD-10, Then there's things like alternative payment models. I said fee for service before, but there's other kinds of payment
Right.
as well. And then there's new kind of technologies. You alluded to having been involved in developing electronic medical record in previous role, but now you've got AI, and you mentioned using NLP and
Right.
interoperability, other things. So how some of these developments, and I just threw out a few different things, but how have some of those developments affected what you've been doing over the last while?
Yeah, so just the expansion to ICD-10, it just increased the complexity essentially, and it will continue to get more complex every time they refine it and they create more codes or they change codes. So that's happening on a quarterly basis. Everything's sort of being updated. So we have to do the updates in our software so that the physicians don't have to do it, right? So everything that we present to them is mapped to the right ICD-10 code for the latest quarter, and so that takes a lot of that off the table. But that's what's created really the need for an automated CDI solution, and then obviously we do a lot of back and forth with the physicians where if you find a complication or a secondary condition that you want the physician to verify is part of being treated, then we have to create an electronic note that basically puts all that in there, and then it goes to the physician to their inbox in the EMR so that they pick it up as a task essentially, and then they can read it, they can check a box and sign it. Then that comes back to us, and that's what updates the documentation profile. So there's complexity around the interoperability with EMRs, and then the sort of value based purchasing and the whole sort of move towards at risk types of payment models is the next frontier, and it's already here. And so a lot of that involves not just inpatient, but now we're talking about the whole population. So people who are going to outpatient or the ambulatory population that are more chronic conditions, right? So now you're talking about a whole different population that you have to track everything that's going on with them, and then it has to be what's called risk adjusted. And just to make it even more complicated, there's about 40 different models between HHS and other payers that for risk adjusting outpatient patients, and that's how they get paid based on the risk adjustment. And of course, the risk adjustment is determined by the acuity and all the clinical conditions that exist for the patient during an eligibility year. So now, because of the risk-based plans, you have to track all patients for a whole year, everywhere they go, capture all the issues, the clinical conditions, and then there's certain hierarchies that get triggered. So the CCs, MCCs, and HCCs, which all roll up into one of 40 models that you have to use to risk adjust the patient in order to get paid.
Oh, sounds good. So you can't do this on like a back of an envelope. You need to actually have some software for it.
Right, and you can't sort of train your way out of it either. You can't just keep training people all the time on how to do this. So it like a lot of things in healthcare, and the reason why people who gravitate towards developing technical solutions, it's incredibly complex and labor intensive if you don't have a way to automate it.
Yeah,
And so that's where we're headed in terms of basically clinical documentation integrity for everyone, not just inpatient population.
got it. So while all these things have been happening, we're now coming up on about the year anniversary of the arrival of everybody's friend COVID-19
Mhm.
in the U.S. What kind of impact have you seen there? Thinking about, certainly from a care delivery standpoint, all of a sudden, they're delivering care in a different way. You talked before about how you might have a patient with, congestive heart failure, and they have kidney failure and so on and so forth, and you're prompting the physician in a certain way. What changes with telehealth? And then just thinking about these, health information management departments, which tend to be a big group sitting at a hospital or a clinic, and they're working remotely. So what are some of the things that COVID-19 have done, and maybe that that next level beyond? We know that people stop going into the doctor's office.
Yeah, so the initially, obviously, last year, it pretty much actually shut down clinical documentation improvement because the way that's done in a hospital is usually you have a nurse who has opted for a career change, who wants to move off the patient floor to being a clinical documentation specialist. A CDS is what they call them. And it's a great job because you have all this clinical experience, and now you're sort of mapping this stuff using the software and helping the docs get it right. Well, what happened in March through October is one, hospitals sort of stopped doing elective surgeries and moved to just treating COVID patients because of the sheer volume of people that were coming in, and they needed staff, and so they pulled the clinical documentation specialists out of their role and put them into patient care. And so it's kind of interesting for us because we just didn't have anybody to use our software, and
Yeah.
so what we had to do then is to now teach people how to do clinical documentation on COVID patients so that they could still get paid.
Right.
And so we did a lot of stuff where we had some of our advisory services staff who were actually doing the clinical documentation specialist job remotely for our clients because their people couldn't do it.
Right.
And so that forced us to develop more of a sort of a hands-on support model, almost like an outsourcing type of arrangement. And that worked really well. And then what you saw, obviously, is in the fall, things started to sort of stabilize a little bit. And now we have another surge. The good thing that the health systems have done is they've adapted to how to treat COVID patients while also treating their regular folks, right? So they've been able to sort of contain it in a way that it didn't completely disrupt the hospital. So what it's done going forward is it's just, once again, it's added a whole nother level of complexity to clinical documentation because now there's this amorphous thing called COVID-19, and what exactly are all the conditions, right, and the symptoms. And so that's an evolving thing that we find out there's 2 or 3 other things that have been attributed to COVID-19. Now we got to make sure that that's part of the bundle, and that gets captured. So I think there's a big sort of burden, challenge ahead for HIM and CDI folks to just constantly be evolving and capturing all of this information while having to deal with treating, everybody in the middle of a pandemic. I mean, it's been pretty crazy, but I think from a CDI perspective, it's just like another razor blade, right? You just add it, and it's COVID-19, and then there'll be something else. So it's good that we have the software. It's just been challenging because the nurses haven't been able to do it. So we've, in most cases, had to do it for them.
So it's like if I compare it with Gillette, they start with like the single blade razor, and then they got like 5 or 6. You got like 18. The thing probably take up your whole face if you tried to shave with it.
Exactly. And then you have the chronic side.
Right.
Right. So once they're discharged from the hospital, then they go into an outpatient mode, and that has to be risk adjusted. So there's new formulas for that. There are new clinical pathways for that. So all of that is just evolving real time, which is challenging, but also exciting. I mean, it's part of what we do. So there is a lot of innovation going on right now, just due to COVID sort of dropping more complexity into an already pretty complex situation.
Right. And plus, yeah, just disrupting where people actually are physically working or what they're working on. So that sounds like a handful. So we just had a change of administration in Washington, new president, Senate's under more or less under Democratic control at the moment, and then new heads of agencies like HHS that are coming. And of course, Biden was part of the Obama administration or the Obamacare. So in some ways, it's a return to where we were. How is there any kind, if you look at it with the CDI lens, any big changes that are coming, or sort of the directions that we were going are sort of still the same? And then there's always, you wouldn't have predicted COVID-19 a year ago necessarily. Maybe you did. Can you see like a change of trajectory now with the new administration, or is it more just business as usual?
I think from a CDI perspective, all of that's extremely standardized. So I don't see that changing, other than the fact that part of the Biden plan is that he's been talking about for a while is expanding coverage.
Right.
So I think that's pretty significant because it's just going to increase volume. And when you increase volume, it adds a burden to the hospital or the provider to once again be able to capture all the documentation so that you get not a penny more, not a penny less for everyone. So if you increase volume by 20%, then you have to be very efficient at not only what you have, but the new volume. And so I anticipate that we'll actually see CDI programs grow and expand. So they'll need to hire some more people, and the software will have to keep up, because you don't want to add people sort of on a one-to-one basis, right? So incrementally adding staff while letting the software do most of the work is where I see things going. So I think as coverage expands, that's good for healthcare. It will probably also tweak through some of the public exchanges that he's talking about, different payment models, different risk models, reimbursement models that will once again require new rules for our rules engine to have to be able to calculate for the benefit of the provider, so those folks aren't having to do it in their head every time.
Great. Well, let me change the subject a little bit here. It sounds like it's been a very busy year for you and for many other folks. And I'm wondering if you've had a chance to read any interesting books. Now, I'll ask you to exclude some of the books that I'm sure you read, like the Hospital Charge Masters and the ICD-10 manuals and so on. But anything on more the leisure or broader business front for books?
Yeah, I actually just finished a book by Mike Wallace called 1945 about the Manhattan Project and the making of the atomic bomb, which is, everybody kind of knows the general story there, but this was really good because it's sort of a pet project of his for like the last 15 years. He's been doing research. So he got really deep into the individuals involved and their background stories and how all of this stuff came together at a level that I thought was really interesting. So if you're interested in history, World War II, it's a great book. So I just finished that about a week ago. I was sort of sorry it ended.
Excellent. No, that's that's very good. Yeah, I felt a lot of the guests have had a chance to read some. It's sort of a split between people that are reading stuff that's just sort of interesting and stimulating versus that's really kind of business and organizational and so on. I guess you got the OD stuff out of the way in your education, so you can move on from that.
Yeah, no, I still like that though. I mean, I have a young guy that I mentor a little bit, and he's just taken on his first leadership role, and so we talk every once in a while, and it's fun because I can give him models to use that help sort of normalize things, and so you don't feel like you're crazy or whatever, and that's been really good from an OD perspective, and I still use those today in terms of planning models and group dynamics and things like that. But you're right. I don't read a lot of sort of management theory
Yeah.
anymore. I just take what I got and I try to apply that.
No, that sounds good. All right. Well, Stephen Mason, CEO of ChartWise Medical Systems, it's been a pleasure speaking with you today about CDI, clinical documentation improvement or integrity, and all of the challenges and complexity that you've been facing and will continue to do so. So thank you very much.
Yeah. Thank you, David. Enjoyed it.
You've been listening to the HealthBiz Podcast with me, David Williams, president of Health Business Group. I conduct in-depth interviews with leaders in healthcare business and policy. If you like what you hear, go ahead and subscribe on your favorite service. While you're at it, go ahead and subscribe on your second and third favorite services as well. There's more good stuff to come, and you won't want to miss an episode. If your organization is seeking strategy consulting services in healthcare, check out our website, healthbusinessgroup.com.